was head of radiology department, and he was doing a lot of pain medicine. So I was doing more of pain also when he was there. So he has offered to kindly take a class for us on IED devices. I think some people will think explosive devices, but it's not that. He's going to shed some light on IED medicine and medicine related skills. Thank you very much, sir, for offering to take the class.
Thank you for having me.
Thank you, sir. Over to you, sir.
Okay, thanks. Okay. So this is really exciting. I've come to this room when it was first started, actually. When I see that, there we go. So what is a implanted electronic device? I'm sure you're all familiar with. Basically, it has three components. So there is a small, so there, can I use a mouse or pointer? Oh, anyway, basically there are three components. There's a pulse generator, which is it. There's a pulse generator, which has got a battery, and the electrodes which are implanted into the whatever target thing is, and the cable which connects these two, right? That's essentially what. And basically what is used for is electrotherapy and modulation, or various kinds of things. So we'll see a bit more details into it. And the ones that is most common and you're most familiar with is a pacemaker, straightforward pacemaker. And you know, I mean, you're the set of physicians, I'm not going to teach you what to do, but this is basically for symptomatic bradycardia. That's what a pacemaker is used for. It could be AV blockers, see. And you know how the thing is. Can you get rid of this or no? Basically, not helped. What did I do? Okay, that's great. That's better. So you know how the nomenclature of a pacemaker is, what is the chamber which is paced, what is the chamber which is sensed, and what happens to the response to the sensing, correct? And finally, what is programmability? This is something the newer pacemakers have, and it's rate model, whether the person is doing an exercise or on a treadmill, it can modulate the rate according to all sleeping, it may come down. So all that, it's an intelligent pacemaker. And this is the lead which goes into the atrium and the ventricle. There's a dual chamber pacemaker. Now, there are other modifiers, right? You must have all seen this, that when you want a patient with a poor in cardiac failure or in poor left ventricular function, you want to coordinate both the left and the right. And you have what we call a cardiac resynchronization therapy, where there is a lead going into the left side and usually goes through the coronary sinus. And so that both right and left are contracted. So it's much more efficient in controlling the rate of the thing and the contraction. And of course, whenever you see these thick leads in the thing on the chest X-ray, that means they are actually what they call a shocking coils, and they can actually cardiovert, defibrillate, or pace. And this is an implantable cardioverter defibrillator. And usually indications are cardiac arrest survivors, post-MI, or history of, there's a risk for sudden death, like in QT prolongation. Same thing with a CRT and defibrillator is available, where you can shock and do the cardioverter. So there are different types of things. Any guesses what these are? Anybody would like to guess?
Take a guess. Third one, an IAB.
Third one. Yes. This one?
Yes.
All right. This is a leadless pacemaker. This is a subcutaneous ICD. When your IV access is bad and you can't put a wire through it. You can just put a subcutaneous, like literally under the skin, and one in the precordium, right under the skin, and you can actually shock it even if needed. So it's a subcutaneous ICD, and this is a loop recorder, like a Holter. It's a loop recorder which records. It's implanted subcutaneously, and it records any arrhythmias and things, and you can get the data remotely. You don't have to take it out.
But it's implanted in the skin.
It's implanted in the skin.
Permanently.
Yeah.
And the leadless one?
Leadless goes into the, it's actually inside the myocardium. I mean, inside the chamber and gets hooked onto the myocardium.
And then after that,
Endocardium, yeah.
And after it's all the wires are removed.
There's no wire, just this. And it's got a small battery and it can actually pace the muscle. As physicians, I don't think you come across it, but we as anesthesiologists are very worried about these patients with pacemakers and they're coming for a surgery, because we work in a very electronically high intense area like surgical diathermy. So electromagnetic interference is a big problem because, of course, but when we talk about that, we always think about a surgical diathermy or an MRI, but there is more to it. Don't forget these things, which is always there when you're inside an operating room. It may be in the fancy watch or a car battery. All of them emit some kind of EMI or radio frequency. And not only that, you can even think of surgeries where there's electrical activity and that can interfere with your pacemaker. So that is the worry. Now, electrocautery, I'm sure you're all familiar from the cautery, is what they use for surgery. There are two types essentially. There is a bipolar or monopolar. Bipolar means there's a forceps and the current passes from one tongue to the other. And the monopolar is an active one, and they put a plate on the leg or back, and the current actually passes through this. And because there's a high current density, it causes burn cautery here, and here it doesn't cause a burn. Now, the problem is a pacemaker senses these electrical activity. The pacemaker say, oh, the heart is beating, so no need to pace. That's a problem. And ICD may sense that there is a VF because of the high frequency. Say, oh, there's a VF going, and may actually shock the patient. So that's the thing. Technically, bipolar is safer because the current area is much restricted, and that's what we would prefer. But many surgeries, you need a monopolar. And one of the things that you have to do, ask the surgeon to give short bursts of, don't do this continuous long thing, short bursts with pauses, and use cutting rather than coagulation. Coagulation disperses much more than cutting. And finally, put the ground plate away between where you're operating and the ground plate. Try to keep the IED away from it, basically, or rather put the plate away so the IED does not come in the channel. You know that MRI is a very powerful magnet. So you may have your patient who you order an MRI. You may have to rethink maybe some other investigative thing, because especially if it's a pacemaker, you can't just take it out. So it can damage the device. It can cause, because of such a high magnetic field, it can actually move the thing, and it can inhibit the pacemaker. It can trigger pacing like in an ICD, or it can actually deliver inappropriate shocks. So there are new ones known as MRI conditional, but beware, they're just MRI conditional. They're not MRI safe. And they may be okay up to 1.5 Tesla, but if you're doing a MRI of the lower limb, maybe it will be okay. But if you're doing something nearby, it may actually cause an artifact. So what we do during the surgery is we can use, you have to, especially if the patient's cardiac rhythm is pacemaker dependent, what we convert it into an asynchronous mode. You all know that basically says it just paces at whatever, 80 or whatever you set it at. Nowadays, all pacemakers are programmable externally, or even from the cardiologist's office, from his phone. He can Wi-Fi, you can remotely. But what we use usually is apply a magnet. It's a round magnet like this, and you apply it right on top of the pacemaker or ICD. Now, one of the things that you have to be careful, I told you these advanced cardiac implantable devices are very intelligent, especially when they change their rate with exercise, they sense the muscle activity or the patient is asleep. So that modality should be turned off before surgery. That is done remotely by a programming device. And if it is a defibrillator function, ICD, the problem is if you put this, it should be deactivated. But you have to make sure this patient may need a defibrillator. So you have to put an external defibrillator pads and be ready with a defibrillator, external defibrillator. And when you apply this magnet, actually it makes a beeping sound, beep for a second, and then you know that it's deactivated. The ICD part is deactivated. The thing about ICDs which have pacemaker, the pacemaker still functions, but the ICD is turned off. And when you take it off also, they make some loud sounds. You have to make sure when you're after the surgery that actually there's nothing wrong with ICD, make sure it's still functioning and you're not done things wrong. So the objective of my talk was, this was just a prelude to that. So there are a variety of non-cardiac implantable electronic devices. I don't know if you have seen, it's not very common here, but it's becoming more and more common for various diseases. Which diseases you do take care of? They actually modulate or control or stimulate a neural or electrochemical controlling function. So there are a whole lot of things. Let's look at some of these IEDs. Any guesses what this could be? Deep brain stimulator. Excellent. This is a deep brain stimulator, and you know what are the indications? I mean, it was started for Parkinson's, but essential tremors, it is amazing what it does to the essential tremors. But this indication is expanding to epilepsy, chronic pain, even depression. There's a big, and of course, everything they were trying out for Alzheimer's. And this is also one of those things. So this is basically what they do is, you pass these leads into the basal ganglia region. So actually you can find the subthalamic nucleus or substantia nigra or the globus pallidus, because rigidity and tremors, they are located differently and they know exactly where to put it. So you actually put it directly and record what they call micro electrode recordings. And you can make out whether the tip is in the subthalamic nucleus or substantia nigra. They can actually make it out. And then they stimulate it. And if the patient has tremors, you see whether it's controlled. But you don't want to over rigidity also. So it's a balance to see which is the. And the second part is that whenever you stimulate the basal ganglia, you can have dysarthria. So they make you say out complex words, and to make sure there's no dysarthria or so when you actually put this contraption is put up and you push these leads through this hole, make a bar hole, and this is recording electrodes, and once you locate it at the right place, they take off all this and suture it and keep it there for 1 week, and then finally the generator is put right under the left clavicle. So this patient needs to be awake because they want to check all these things. So we give scalp block to make them numb, and we give IV propofol or dexmedetomidine, which has become a big thing in neuro anesthesia now. So, all right, anything else? Can you guess this? Perfect, very good. Yeah, you see that 2 spots there? This one, you see that? So that is a vagal nerve stimulator. And what do you use it for? So it was started again for medically refractive seizures. And it basically increases the GABA in the brainstem. But the indications have increased to intractable hiccups, obesity, and depression. And this is something very recent. We did a case for this, which I was not aware of this. And they've used for post-stroke rehabilitation. Apparently, it helps the muscle activity thing. which I had not heard before, but there is thing. And finally, this is something very new, immune modulation via the vagal afferent to the spleen. So much, have you heard of this? The rheumatoid arthritis, it is used for rheumatoid arthritis. Again, about 2 months ago, we did a case for this with rheumatoid arthritis. I had never heard of it. So much so, they're now doing splenic artery stimulation to, that's where apparently spleen is involved with all immunological problem, and that is used for rheumatoid arthritis. So there you go. This is something which is totally new for me. So basically, you dissect out like a carotid endarterectomy, you dissect out the thing and literally find the vagal and wrap the electrodes around it, and you implant the generator like this. So here they don't do any monitoring. So they just so you can be asleep, patient can be asleep with an intrathecal tube, and you put this thing. But the only thing you have to watch out, sometimes when they stimulate, you can have bradycardia and bronchospasm. So something we have to watch out for. Any idea?
Sleep apnea or something. There's a device up there.
Look at that. No, that is, I think, a spine
okay.
thing. But you see this lead, and there is a lead here. There's a better picture which shows. That's what hypoglossal nerve stimulator. So what they do is, basically the impulse generator implanted below the clavicle, and this is implanted between the two intercostal muscles and senses the breathing. And then if the breathing is obstructed or limited, then what they are apneic, it stimulates the hypoglossal nerve, which supplies the muscles of the tongue, protruding of the tongue, to get the tongue out of the way from the pharynx. So this is where, so obstructive sleep apnea, obviously in adults, but the lot of patients with Down syndrome, children with Downs, they're using more and more of this because they get obstructed, they can't like fat. So the hypoglossal nerve supplies all these muscles, and the pleural reed is sensing the breathing. Now, when they implant these things, obviously we give general anesthesia, but they want you to not to paralyze them, so that when they stimulate, they can actually see the stimulation of the muscle. So they want the patient asleep, but not paralyzed. So the other thing to watch about is when they blow the pleural one, you may create a pneumothorax. So at the end, just be careful about that. Now, this is interesting. Any idea? This is a patient who has a cardiac, pacemaker and a hypoglossal nerve stimulator. You can see the pleural one. So you may see patients with both, and you can expect them, patient with a cardiac problem and an obstructive sleep apnea has both these. Actually asked the surgeon, we do quite a bit of this. So the surgeon said, hey, why don't you why don't you use this slide? Because this is, you get more and more than one acute IEDs in the patient. Any guesses about this? Huh? Sorry? Good guess. This is a gastric stimulator. You can see it's basically implanted into the curvature of the stomach and used for gastroparesis. And now it's obviously treatment for weight reduction. It's a big thing to enhance the movement of thing. But interestingly, I had a case about 6 or 7 months ago. There's a about 29, 30-year-old girl came with intestinal obstruction. And finally, we found that she had this thing, and the loop had coiled around this. See, this is up to here in the skin. After that, it has to get into the abdomen. So, when the coils of the bowel have gone around, and she went into severe obstruction. So, there you go. So, we basically give general anesthesia with endotracheal tube. Sorry? No guesses?
Bladder.
So this is a sacral nerve stimulator. This is for sacral neuromodulation, and the indications are quite a few: urinary incontinence, urinary retention, fecal incontinence, a whole lot of. And these are the kind of disease: Hirschsprung disease, spina bifida, idiopathic constipation, rectal malformation. And what they do is patients lying prone, and they try to find the sacral S3 nerve, find the sacral foramen here, and pass the electrode just enough to stimulate the S3 nerve. And how it happens when you stimulate it, there's a great toe dorsiflexion, contraction in the perineum and ale. This is known as bellows reflex. Patient complains of paresthesia in the scrotum vaginal region. So actually, when they put the temporary lead patient, you need to get the patient awake. They need a sedation and local anesthesia. But when you're finally putting the generator, you can give general anesthesia and implant. But this is being used quite a bit for incontinence and this. That looks in the spine, right? So it's a spinal cord stimulator. This is actually, I remember about 25 years ago, somebody approaching us from here, from Australia, wanted to start this because we get a lot of patients, especially with PMR, the spinal cord injury and pain. So this is used for chronic intractable pain in the back, trunk, or even extremities. And one of the biggest indications are the failed back surgery syndrome, which is there. Or it can be regional pain syndrome. Even intractable angina, it has been suggested for stimulators. They used to do it, not so common now for some reason. Or it can be pain in the extremities from nerve damage. I say the traffic accidents, they can do it. So basically, what they do is Tuohy needle, the epidural needle is passed thing, and this electrodes can be passed inside. Now you can predetermine what level you want it, because depending on where the pain is, and leave it like that. Or when you put it, you stimulate and ask the patient, are you getting paresthesia in the same place where the pain is? Then of course it works well. So you can have an awake patient or asleep. So many surgeons, depends on how the patient's acceptability is. So it can be done. But remember, it's in prone position there to get at the back. Usually a fluoroscopic guidance. You may have seen this. This is an intrathecal pain pump. Now, FDA has approved 3 drugs that can be given through this: morphine, ziconotide, and baclofen. You must have seen baclofen injections at least here. And of course, the morphine basically acts on the primary afferent neurons or the dorsal horn, presynaptic or postsynaptic, basically inhibits the release of substance P and calcium GRP, and it hyperpolarizes the postsynaptic neuron. Just to know the mechanism of how morphine works. Ziconotide is basically blocks specific N-type calcium channels and used for analgesia. And baclofen is very popular because it used for muscle spasms, spasticity, neuropathic pain. The alternative is to give Botox injections nowadays, but this is very, very popular for baclofen pump. And these children come back for refilling the baclofen. You can just inject it through this port. It's subcutaneous, you just refill it through that. And very useful, very, very effective. This is something very quite, not recent, it's at least 5, 6 years old. But this looks quite interesting. It's what we call a responsive neurostimulation system, or neuropace, and patients epilepsy unresponsive to medical treatment. So basically what they do is there's a monitors on the temporal lobe where they detect where the origin of the epilepsy would start, and they recognize pre-epileptic activity. And once they sense that, it automatically delivers a pulse of electrical impulse it's basically like an ICD for brain. just like an ICD, because it senses something is coming on, it gives a surge and they just neutralize it. So this is one of the case I had done about 5 years ago. So basically, this patient is sitting up. If you can imagine, there's the back of the head and is sitting up. They want to put this under the back in this region and put the leads in the temporal region. So they operate that and get the cables through here. And of course, it's a sitting position. Whenever you chip off the bone from the cranium, there's a chance of air embolism. That's one of the dreaded complications of sitting position. Now again, the new RNS 320, which is available, which is MRI conditional. Nothing is MRI safe, but this is the best you can get. And whatever, even the older other variety, other models, basically you should turn the MRI mode on. What it does is it stops detection and stimulation is off. So that, because there will be a whole strong magnetic field that can cause problems. So you see there's a whole lot of IEDs which are not cardiac related. And if they come for any surgery or procedure, the general thing is turn them off. Because unlike a cardiac where you can't turn them off, because this life does not depend on this, but you can control all the other things like sleep apnea or epilepsy. All this under anesthesia can be controlled. But cardiac thing, of course, you can't turn it off. So this one, turn it off if you can. And again, the same principles, beware, don't put the pad close to the generator and try to use bipolar whenever you can. MRI, again, these companies are coming out more and more with MRI conditional devices, but it's a problem. It will, especially if it's like, for example, the one on the brain, it will interfere with your MRI. It will create a big artifact. So those are the problems of this. Actually, we had recently had a patient who had a spinal cord stimulator and had some tumor detected on CT, and they had to do an MRI. They had to take out the leads out because otherwise you can't do an MRI because you won't see anything there. So that is the problem with this. So the thing is, now more and more the things have become wireless and you can control it remotely. And I don't know whether you saw a movie recently where there was one actor who had they detect that he has got a ICD and they remotely control it and actually shock the patient. There's a movie which came out. But maybe this is a site for cyber attack now, maybe that's the future. So not every IED is a pacemaker. I just talked a few. There's, as somebody said, there's a phrenic nerve stimulator for patients with ALS, diaphragmatic stimulator. But we do that surgery, but we don't implant those mainly because the patients don't survive that long, but they are external generators. So that's there. I mean, of course, you insulin pump, cochlear implant. I'm sure it's just going to increase this list. And you're going to see more and more things. So maybe my next patient will be like this, right? And so I'm sure it's just a matter of time before you'll be seeing all these things. So this is a view of fall colors in our place.
Penn State?
There's a bit north of Penn State. This is known as Maine, but we went last October there and it's beautiful, absolutely. Actually, you can, that's Reka. It's a big lake and there was a color, it was a Japanese garden. Yeah. So, thank you. And any questions?
Any questions? So these are outpatient, like the patient comes in the morning, go by evening, or they have to stay for a couple of days to get it done?
For the implants, many of them, like for example, the DBS, they will do the first sitting and they go home with that cable outside and the generator outside, and they use it for a week, make sure everything is fine, and then they come back a week later and gets implanted. They tunnel it underneath and implant it here.
That's done by anesthesia?
I mean, no, done by neurosurgeons, but under anesthesia. The second stage, they don't need to be awake. The first stage, yes. So they like that. So that's what vagal nerve stimulators for seizures. We do all these things that I think pretty. DBS is the most frequent, of course. Vagal nerve hypoglossal is because we got a big population of obesity and obstructive sleep apnea is a big problem. Actually, so much so in Pennsylvania, it's generally if you get 100-kilo patient, it's a good day. Because usually it's about 200 kilos on an average list. So we have big obesity is a big problem.
And it works. You can see visibly that they are better after that.
So they do a study, they do a nasal endoscopy and the sleep nasal endoscopy. I'm sure they do it here also. And once you detect, and basically the tongue is falling back in the thing. And this, you can try CPAP and all that machines. And if not, there's many people can't tolerate a CPAP. That's the problem. So they'll say, okay, they'll try this. So quite a few are coming now, hyperversive. In the last 2-3 years, it's picked up. I'm sure there's a fad. These are all equipment. They're expensive. They have problems, infection. All that is there. So till you have a learning curve, go through it, you'll have this problem.
So is there a training program for each of these, or it's like?
The companies will make sure whoever's interested in like the hypoglossal thing is done by the ENT group. They are the ones.
And the neurologist or neurosurgeon, just the deep brain.
Neurosurgeons, but the epilepsy, the neurologists are around because they know it's their patient, but the implant is done by neurosurgeons.
And the other ones, the spinal cord stimulation and bladder and all.
That can be chronic pain. People, they do it. Who have actually anesthetist background, but just putting that thing, they do. But the sacral nerve and all are usually done by the neurosurgeons, or even general surgeons, they do it. Yeah, because, and ALS, of course, the one which you were saying, the diaphragm stimulators or the phrenic nerve is done by the general surgeons. Yeah, it's
amazing.
I hope it was.
Yes, of course, it's fascinating new world for us.
Yeah, but I'm sure there are places here which does DBS. I know Sri Chitra does it. Random DBS is there, and I'm reasonably sure somebody told me Indian Hands also. We are not doing it here, but I'm sure there's a matter of time before it comes here.
Any questions, guys? We'll give Dr. Verghese a hand. Thank you very much, sir.
Thank you.
Thank you, sir.
All right.
Really enjoyed.